So hi everyone, thank you for having me today. I will be presenting on behalf of my two other colleagues, Associate Professor Christopher Etherton-Beer and Professor Sandra Carr, who worked with me on the Depth of Field Exploring Ageing project. For those of you who don't know what Depth of Field is, Christopher Etherton-Beer is a geriatrician at Royal Perth, and he and I met back in 2014, decided to pilot some reflective learning tools because he was concerned that the medical students weren't really interested in going into geriatrics, and he felt it was due to some negative attitudes and stereotypes they might have towards older people. So we got together and did a pilot, and that's how the Depth of Field reflective learning resource sort of was born. What it uses is it uses photo-elicitation techniques, which I have used a lot in my research, and it also uses patients' narratives. So this resource was driven by consumers. It was driven by a group of older people living out at Bethany, Jundana, and what it does is it's a bit different to normal health professions educational resources in three ways. First of all, it focuses on pre-flexion. You know, we do a lot of reflection in action and after action in health professions education, but we don't often focus on anticipatory reflection, or what we call pre-flexion. And this is really important in relation to emotional preparedness for students going into clinical practice. The other way that it is different is that it inverts the traditional ways we teach health professions because it gives no context. You know, normally we always say, here's a 89 man presented to the emergency department. It actually just puts a photograph and it asks the students to construct the shared storyline. And because we do it this way, and through the research I have worked in ways that we can juxtapose the photographs in certain ways, it prompts reflective learning by creating a cognitive discrepancy between what the student thought they knew and then what is actually presented at the end of the session in the patient's own words about their story. So that sort of creates a bit of a vacuum where all their unexplored stereotypes are surfaced and they're able to explore them before they go out and prac. So we thought that we wanted to evaluate the resource, and so we used a mixed method evaluation design to ask three questions. What are the perceptions of a group of second year medical students prior to their first geriatric clinical placement? How do photographs, narratives and small group collaborative dialogue influence reflective learning in medical students? And what effect does this reflective learning technique have on their attitudes towards caring for older people? We received ethics from the UWA Research Ethics, and I conducted 8 one-hour sessions of depth of field sessions with our second year medical students last year, and 128 volunteered out of 240 cohort. And they completed a pre-questionnaire which looked at their age, their gender, any previous work or close relationships with older people, and a 13-item validated geriatric attitude scale. And then they did the session with me, and then they did a post-questionnaire and were invited to submit an individual written reflection within 4 weeks while they're out in their geriatric rotation. And this was linked to a portfolio asset in the MD course. We used descriptive statistics to look at the demographics, non-parametric Wilcoxon signed rank test to look at the pre and the post questionnaires before and after the depth of field, and then thematic analysis to look at the written reflections that they submitted. The results were that we got a sample of that was quite similar to that of the whole of the cohort, with 55% female, 45% male, and mostly between the ages of 20 and 30 years. 65% already had established a close relationship with an older adult, and that was quite fulfilling for them. And 61 had indicated previous work with adults, which was not surprising since it's graduate entry now. Some of them have already been allied health professionals. And then we saw in the questionnaire with the pre and the post responses that there was a significant overall shift in responses from 8 out of the 13 items. And you can have a little look here at the different items. Most of the constructs are around the value of them caring for older people. In relation to the qualitative themes, we found 4 themes. The first one was that this process allowed them to envision, which is what we wanted in terms of preflection. I think I will feel. And a lot of their responses were quite emotive, which is the use of the photo-elicitation techniques, and art is emotive feelings. And they included apprehensive, frustration, overwhelmed. Sometimes I imagine I would feel sad and helpless upon viewing someone who is decrepit and terminal. And this is what we found quite surprising, is that their overall pre-results questionnaire showed they had positive attitudes towards older people, but actually that was contradicted in their written reflections, and that can sometimes be from the unexplored assumptions or the terminology that we use to describe older people. Secondly, we found that it did create tension, which is what we wanted. For example, they said, I never imagined that an older person can do these things. So they were surprised at what the older adult can do, and that contradicts what they thought. And they surprised themselves because some of them often felt slightly guilty or uncomfortable having jumped to conclusion about what the older person, adult, can and cannot do. And this is the core of reflective learning and transformational learning that shifts perception. So we want to make them feel uncomfortable so they can have a good look. And this caused them to dismantle some of the assumptions and to explore where they might have came from. I love this one. All the older people seemed happier than they should be. They surfaced students' assumptions and began their exploration around where they came from, including the media, relationships with previous older people. And they found value in hearing others' perspectives because they were all constructing a story of the same photograph. Some people would see the older man as really sad, and another thought he was quite stoic. The different interpretations of the photographs was valuable for student learning. And the fourth one was seeing the person. I learnt to never judge a book by a cover. And I think we saw a growing sense of empathy in the students, and they were mindful of how this potential impact of these unconscious bias might have on them being the type of doctor they want or to be able to practice patient-centred care. So finally, the simulation methodologies of using photographs and narratives in preflection created conditions that facilitated reflective learning. And although the pre-questionnaires, like I said, fell in the positive range, the written reflections were quite different. They were lots around low quality of life and high morbidity. There was a positive shift in both the quantitative and qualitative data that suggested that they had a widening perspective, a growing empathy and active deconstruction of where these assumptions might have came from, particularly in being open to engaging with older adults, and that was items 2 and 13, and also being open to hearing their stories. And depth of field encourages medical students to surface and recognise and question these unexplored assumptions towards older adults. We'll be presenting the findings in Melbourne in September at the Australasian Simulation Conference, and we also have a paper under review at the moment. And obviously all research project outputs will acknowledge the funding we received from you. So, is there any questions?
Hi, I'm Anne from Hollywood. Just so I'm clear, so the photographs and images you showed, were they of the actual patients that they would be seeing later in the... No,
they were of older people. But actually they do placements out at Bethany. So some of the volunteers who developed it with me, the older people that live out at Bethany, they might see them in their second rotation by being out there. But generally it's just in regards to older people, yeah.
My name's Heidi Waldron. I'm from Notre Dame University. Thank you, that was amazing. I really like the way that you've used photographs to prompt their reflection. I was wondering, with your mention about not providing context at the beginning, did you then provide the actual context for that patient so that you could challenge their assumptions afterwards?
Yeah, that's a technique that I've developed over a couple of years, where if you give them no context, all their assumptions will come out in their storyline. But if we juxtapose the photographs in certain ways and we draw out the patient's real narrative that we know that will contradict the generalised stereotypes and present it at the end, then it creates that cognitive discrepancy. But they are the patient's real narratives. Because I'm a narrative researcher, I interview them and during that I could draw out the contradictions in the narrative, but also, you know, we challenged sexuality with older people. One of the men had an amputation and then showed some war medals, so they're saying, well, he lost his leg in the war, but he actually hadn't, and he tells them in the videos in the depth of field that he lost it from a stroke only 18 months prior. So we've sort of developed a way that we can contradict the narrative, but the patient's voice in his own words and his own stories at the end. Does that answer?
So sometimes when the students then provide their reflection, do you find other things come up that you hadn't anticipated as assumptions?
Yes, definitely. And even some of the things that they came up with I hadn't actually thought about. That was quite interesting. Like, there was a lot of information about their nervousness around history taking and those types of things around with older people because of their memory and that I hadn't actually thought of prior. So it was interesting.
Thank you.
No worries.
Thanks very much.
Thank you.